IAP THRISSUR, especially Dr. Latika and Dr. Nisha for a session, even though the attendance is less, don't have joined today. And so we have our dear Prasanth simply be enriching not only for the students, but for each of us. All the best for the program. Thank you.
Anand also.
Good evening, sir. I think we can start the scientific program. Anyway, I congratulate IAP Kerala and also the regional coordinator, Dr. Latika Nair, for conducting the program very promptly and very enthusiastically. The poor attendance may be due to upcoming university exam. Especially Thrissur, there is university exam. I think other medical also there is university exam. So I wish the program more success. Jai Hind, Jai IAP. Over to Latika.
Prasanth needs no introduction. Prasanth Trivandrum Gastroenterology head pediatric gastro head we couldn't Parnilla Thrissur Medical Ameliano.
Where is me? Thrissur Medical College.
Thrissur.
Cases from GMC Thrissur.
Okay.
Vismaya Thambi Ganesh.
Start the Latika.
Okay, sir. Vismaya, you can share your slides.
Video voice.
Sir, I think നമുക്ക് എക്സാമിന് ഡിസ്കസ് ചെയ്യുന്ന അതേ ഫോർമാറ്റിലായിരിക്കും. അപ്പം ലൈക്ക് നമ്മൾ സമയം അതുപോലെ പാലിച്ച് തന്നെ ആയിരിക്കും പോകുന്നത്. ഹലോ,
അത് നന്നായിരിക്കും.
അതായത് സാർ പുരുഷോത്തമൻ സാർ നമ്മൾ എക്സാമിന് പോകുന്ന അതേ പാറ്റേണില് ലൈക്ക് ഹിസ്റ്ററിക്ക് ഇത്ര സമയം, ഫിസിക്കൽ എക്സാമിനേഷൻ ആ ഒരു പാറ്റേണിലായിരിക്കും നമ്മള് ഒരു പോകുന്ന. എന്റെ ഒരു സജഷൻ സാറ് പറയുന്ന പോലെ
ആയിക്കോട്ടെ. കുറച്ച് ഇതിന്റെ അകത്തുള്ളതെന്ന് വെച്ചാൽ എക്സാമിനേഷന്റെ അകത്ത് ലോങ് കേസിന്റെ അകത്ത് യു വിൽ ബി ഗെറ്റ് 30 minutes ഓൺലി. Here we will get 1 hour for the discussion.
Okay, sir.
1 hour for the presentation and maybe 10 minutes for the discussion. So കുറച്ചൊരു ലെങ്തി ആക്കാം, കുറച്ച് elaborate ചെയ്യാം. പക്ഷേ ബേസിക്കലി
പിന്നെ അതുപോലെ സാർ ഒരു കാര്യം കൂടെ, ഐ തിങ്ക് വി വിൽ ഹാവ് ഡിസ്കഷൻ immediately after the symptom analysis, then after the conclusion of the history, then after completing the physical examination. So we'll have discussion at 3 levels before going to the workup.
Right.
Vismaya, be quick. All the best.
Thank you. Good afternoon. Respected teachers and my dear friends, good afternoon. I'm Dr. Vismaya, presenting a case of 93-day-old boy from Thrissur. Date of
Vismaya, can you be little more louder? You're not audible properly.
Okay. 93-day-old boy from Thrissur. Am I audible, sir?
Yes, audible. Please proceed.
Thank you, sir. 93-day-old baby boy from Thrissur. Date of birth October 23rd, 2024. Date of admission January 23rd, 2025. Informant mother. History is reliable. Presenting complaint: high colored urine for 1 month, pale color stool for 3 days. Antenatal history: is the first child of non-consanguineous marriage, born to 25-year-old mother and 32-year-old father. Father taken treatment for low sperm count. They conceived 1.5 years after marriage. Pregnancy confirmed by urine pregnancy test 1 week after missing period. They have a regular antenatal checkup and no history of abortion.
Vismaya, please hold on. Why are you jumping from the history directly to the antenatal history? This is the usual format that you follow in examination.
Sir, as the child present.
No. You have just listen to me. You have presented 2 symptoms. Without going into the details of symptoms, why are you directly jumping to the antenatal history, etc.? Purushothaman sir, please correct if I am wrong.
Anyway, just one sentence before that you could have said in the examination, as the whole problem started, or maybe having relevant to have the details starting from birth. അങ്ങനെ ഒരു വാക്ക് പറഞ്ഞിട്ട് സ്റ്റാർട്ട് ചെയ്യാം, അല്ലെങ്കിൽ ഇതുപോലത്തെ കൺഫ്യൂഷൻ വരും. അത്രേ ഉള്ളൂ.
From start with Vismaya told, it is given to understand that the problem started just 1 month prior to the hospitalization. That was the impression that she gave. Okay, since you have prepared that way around, I feel like you should have an analysis of the symptom If it is so relevant and intermingled with the neonatal history, probably you can start from that time onwards. And if need be, start from the antenatal history also. But that connect has to be established in the first statement itself. That is apparently missing from your first slide. Okay, Vismaya, please proceed.
Thank you, sir. First trimester, dating scan done, folic acid tablet taken, no history of radiation exposure, mother had history of fever and cough in first trimester, diagnosed as upper respiratory tract infection and symptomatically managed. No history of rashes or lymphadenopathy, no history of other drug intake. Second trimester,
Vismaya, 1 second, please go to the previous slide. Why have you highlighted mother had history of fever and cough? You have highlighted that particular part of the slide alone. Why you have highlighted that? What is the purpose of highlighting? Or I think I will call Dr. Samiha. Is she around?
Sir, because the baby is 3.
No, not Vismaya.
Mother had history of fever and cough.
Who is Dr. Samiha? Is she around?
Sir, it is a positive history, so I have highlighted that because in first trimester, if mother had some infection that can cause jaundice in child, so that I highlighted that.
Okay. Okay.
Dr. Suraj is a PG.
Okay. Dr. Suraj is around? Okay, we'll leave it. Okay, proceed.
Second trimester, Yukni felt at 5th month, 2 doses of TD taken, iron, calcium, folic acid taken, no history of urinary tract infection, gestational diabetes mellitus, gestational hypertension, bleeding or leaking per vagina. Anomaly scan showed choroid plexus cyst of size left 5.4 centimeter, right 3.9 centimeter, and so that non-invasive prenatal testing done to rule out aneuploidies, including chromosome 21. So the result was normal, low risk, because choroid plexus cyst is a soft marker for Down syndrome. So that they have done non-invasive prenatal test.
Just go back to the previous slide. Yes. Go back to the previous slide. You have mentioned emphatically, like you have given a no history of urinary tract infection, no history of GDM, no history of gestational hypertension. What is the relevance of those negative history?
Sir, UTI mother can cause sepsis in child, and
we are referring to no, Vismaya, we are referring to trimester 2. Okay, you please go to the next slide.
Third trimester, good fetal movement. Well, mother had gestational diabetes mellitus. She was on diet control and values were normal. And she had gestational thrombocytopenia. No history of gestational hypertension or preeclampsia. No history of itching over body. No history of urinary or premature rupture of membrane. No history of intake of alcohol or other medication. Mother had 10 kg weight gain during antenatal period.
That is the relevance of those negative history which you have alluded to in the current slide in relation to the particular symptomatology of the case.
Sir, itching or body can in mother there is chance of progressive familiar intrahepatic cholestasis history can be there if child presented with cholestasis. So that I. And in urinary tract infection and premature rupture of membrane, sepsis in child can cause jaundice.
Okay.
Natal and postnatal history. Baby born by a normal vaginal delivery at 39 weeks, 2.99 kg, appropriate for gestation age, cried soon after birth. Breastfeed immediately after delivery. No history of NICU admission. No history of respiratory distress soon after birth. No history of neonatal jaundice. Blood group of mother and baby was B positive. No history suggestive of neonatal hypoglycemia. No history of total parental nutrition. Meconium and urine.
Previous slide. Previous slide. What is the importance of all those negative history which you have mentioned?
Is if
You
child
take-
didn't cry soon after birth,
You take
asphyxia
one by
is
one.
there.
You take one by one.
Baby cried soon after birth. If baby didn't cry soon after birth, there is asphyxia. Asphyxia can cause liver injury and lead to cholestasis. And then no history of neonatal jaundice and no history of neonatal hypoglycemia. Hypoglycemia symptom can be occur in galactosemia if soon after intake of breastfeed, galactosemia symptoms, hypoglycemia can be there. And if baby taken any fructose containing fruits, fruit juice or syrup, that can also cause hypoglycemia. Hereditary fructose intolerance is there. And in mitochondrial hepatopathy, there is chance of hypoglycemia is there. And in tyrosinemia also, there is chance of hypoglycemia. And that also these cause neonatal cholestasis or jaundice, and total parental nutrition can cause cholestasis and jaundice. That way I asked this question.
This would have been more appropriate if you had elaborated on the symptom. This looks like just a checklist of what is given in textbook, having no connect with the case per se. So this is the problem of, I feel some kind of a disconnection between the actual symptoms and whatever you are narrating. Okay, please proceed.
Meconium and urine passed within 24 hours. Baby discharged on postnatal day 3. At discharge, baby feeding well. Urine output was adequate. At the time of discharge, yellowish discoloration of eye was there, but no yellowish staining noted over legs and forearm as per mother.
Just hold on. What is the relevance of the first statement? Meconium and urine passed within 24 hours in relation to this case.
In hypothyroidism, delayed passage of meconium can be there, and it causes jaundice. Can cause jaundice.
But do you expect hypothyroidism to go unnoticed until 90 days in a state like Kerala? I mean, I'm asking with reference to this case, not a general textbook description. In the given case, given setting, suppose you say you make a statement like meconium and urine passed within 24 hours. What does that signify? Is the question clear?
So,
who is Dr. Hari Krishna? He is around?
65
Hari Krishna, Hari is here. Rinshida is here, Rinshida.
Okay, Dr. Rinshida. No, please feel free to answer. Even if you make mistake, no, this is not going to be an actual examination.
Hello,
Or
sir.
may I try to answer?
cystic fibrosis.
Cystic fibrosis. Okay. Okay. No, the previous slide. It is not over. Previous slide. Baby was discharged on day 3. At discharge, baby feeding well, urine output adequate, yellowish discoloration of eye was there. But immediately thereafter, you are making a statement that, but no yellowish staining noted over legs and forearm. What do you want to convey? You are contradicting. You are contradicting your own statement. I think in the previous slide, etc., you are mentioning that there is no history of jaundice, neonatal jaundice, but that in the postnatal history slide, there is a suggestion of jaundice. Am I right?
So that's a mistake. Sorry.
Ismaya?
Yes.
Yes. Okay. Examiners will be very shrewd to pick up points from your whatever you say. So be very, very careful. Now, all this happened because you started from the antenatal. Okay. What is this?
After the discharge, child had multiple hospital visits. So I have put in a table.
Why the hospital visits happened? It was all scheduled or unscheduled?
Unscheduled, sir.
Why?
With multiple complaints.
Complaints are not clear.
Complaints on days 7, 14 and 30. Baby visited in the hospital with complaints of yellowish discoloration of eye. And at that time, stool color and urine color was normal. And they have advised proper breastfeeding. On day 7, 14 and 30. On day 48, they have first immunization visit. At that time also, urine color and stool color was normal. And on day 64, they first noticed dark yellow color urine. They not consulted nearby hospital because they thought it was due to intake of vitamin D syrup. And on day 76, baby had incessant cry at home and admitted in nearby hospital for observation. They have treated with some Colicate drops. After the admission, baby had no incessant cry. At that time also, stool color yellow and urine color was dark. They first noticed a change in stool color on day 82. And they had second immunization visit at day 86. At that time, urine was yellow color and stool color was light yellow.
Just hold on. Previous slide. So suppose you have, the next slide. Next slide. Suppose you happen to see the child on postnatal day 76 with a background of jaundice and incessant cry. You should be worried about something serious happening. What is that worry?
Jaundice is there and incessant cry.
No. Jaundice is there. That background history is still there. On top of that, you are seeing a baby who is incessantly crying. So what complication you should be worried about?
Hepatic encephalopathy.
Encephalopathy. But the baby was apparently normal. Something has happened suddenly. Okay, we will reserve that question subsequently.
On day 91, they first noticed a pale color stool. On day 93, they consulted nearby hospital in view of pale colored stool persisting. And from there, first investigation done, total bilirubin 7.2 and that.
Vismaya.
The weight gain initially was low. They had some feeding issue. And
Vismaya, please listen to sir. Sir is telling something.
Vismaya.
കേൾക്കാം.
The first odd point at the beginning itself, as Dr. Prasanth was highlighting, your presentation, a normal baby up to 60 days and from 60th day onwards, the cholestatic type of a picture evolved. And actually, when you are describing now, it started still later. 70th day onwards, urinary discoloration, like that was a little atypical than the commoner presentation of the cholestatic newborn babies situation. Okay, so you need to explain why I am going to start from the antenatal period. That is one thing, because you may get this question like that, because most of the cases, the cholestatic type of picture usually starts somewhere around second, third week onwards. It won't be that late. Nothing is impossible in medicine. There are conditions where the basic etiology dates back to early period, but a little later presentation is there. So that's an important thing for our diagnosis in this case. For that, very, very important thing is, don't give too much importance to the description. You need to decide by observing the samples. In any case, 5 samples you need to see, the clinician need to see and decide. One is you need to ask for the urine. You need to ask to show the color of the stools, and maybe in an older child, the dress, the handkerchief and the munde, all those things. Okay, so macroscopic sample, out of which most important is the dress. So what is the staining of the dress? It's not the conventional diaper. Diaper നമ്മൾ പറയുന്ന snuggie അല്ല. തുണീന്റെ അകത്ത് ഉണ്ടാവുകയും usually even after washing, the color will be remaining. So it's your duty to verify that. Then only say it didn't appear early. It started from 76 days എന്ന് പറഞ്ഞ history മാത്രം പോരാ. ശരിക്കും നമ്മൾ എന്നെ patient is coming on the 7th day, 14th day onwards ഇങ്ങനെ frequent ആയിട്ട് വരുന്നു. അങ്ങനെ സിറ്റുവേഷൻ്റെ അകത്ത് make it a point to see the macroscopic appearance of urine, stool and the dress, especially the cotton napkins used for this thing. ആ 3 കാര്യം important ആണ്. And about the antenatal period choroid system situation പറഞ്ഞു. Very, very important. 2-3 ways. 2-3 ways antenatal period important because genetic syndromes are the, out of which Down syndrome is very important. Choroid cyst situation is one of the reasons for cholestatic disorders and hypothyroidism. അങ്ങനെ വരാം. അതുകൊണ്ട് antenatal period കാര്യം, growth part, all are important. About the neonatal situation, rather than mentioning hypoglycemia like that, so just like Prasanth said, overall situation of the newborn baby, newborn period is better because this baby was okay and was discharged on the 3rd day. So that will help you to rule out many of the conditions because a patient is having jaundice at 90th day started according to you from 2 months onwards. Okay. So it can be any of the jaundice. The direct or indirect bilirubin, many of these things. There are hemolytic disorders, later onset, cholestatic disorders. And out of these things, reasons for the cholestatic situations are metabolic problems, intrauterine infections, okay, and other structural disorders, many are there. Okay, out of which, how sick was the baby during the newborn period? So that is enough. Whether the baby was fit enough to be discharged on the 3rd day rules out many of the sick situations. So metabolic disorders of severe types, all of you know, all of other discussion, hemochromatosis situation, tyrosinemia situation, galactosemia situation. None of those situations you will be able to discharge the baby on the 3rd day and not getting readmitted in those periods. So overall description of the clinical situation of the newborn period will help you to say the possibility of the 6 situations of a sepsis or an inborn errors of metabolism, how likely it is. Now comes the situation of, is there a possibility of something dating back to that period, onset very late? So such situations are there. Few of the metabolic disorders which are slowly progressing. Few of the intrauterine infections which are asymptomatic in newborn, later presenting, like your cytomegalovirus, like sometimes a urinary tract infection, like that. So that is how you should be utilizing the history to explain this thing. Okay. So rather than going to the hypoglycemia now history and that, how sick was the baby during the newborn period, that would have been better for the description. Okay. Go ahead. Prasanth, anything more?
Sir, even though she is mentioning that the history started very recently, there are very good pointers in her own statement that all the process started right from birth onwards. Because that jaundice has been there and the baby had multiple point of contacts in between until the diagnosis was made, but nobody bothered to do a fractionated bilirubin, or nobody bothered to check the urine color or the stool color. Probably it could have been a little more earlier, but even though she has mentioned it like starting after a gap of 90 days or so, the process has set in right from the neonatal period itself.
Sir, first point of contact is on 93rd day, 94th day only. Till
No,
then,
no,
she
no.
was consulting in other hospitals
No,
only.
no. I was referring to the, I was
Other
not
hospitals.
telling that in the
Yes.
in your sender. Before that, you have highlighted that the baby had multiple visits. That was
Yes,
what I
yes.
was
From
referring to.
history. From history only we are getting.
Okay. Gibson, who is Gibson? Gibson is around. Rosemary is around. Rosemary.
PGs,
Litya?
please unmute and answer.
Is
Yes,
Dr. Gibson around? Gibson around?
Yes, sir.
Gibson is there.
Yes, sir. Yes, sir.
Gibson, how will you distinguish physiological jaundice from a cholestatic jaundice? Is my question clear? Gibson?
Physiological jaundice will be end within 2 weeks. If cholestatic jaundice
Who is answering,
persisting more than 2 weeks.
Rosemary or Gibson? Ismaya is answering.
Yes.
Ismaya, please mention the attributes of physiological jaundice.
Physiological jaundice mainly due to decreased feeding. It present after 24 hours.
No. Please don't go to the mechanism. Just mention the trajectory. When it will start, when it will peak, when it will come down.
Usually it start after 48 hours and it will come down within 2 weeks. If cholestatic jaundice, it will persist after 2 weeks. And if there is cholestatic, there is chance of pale colored stool, sometimes yellow colored stool. If severe jaundice, intestinal epithelium can also jaundice, it will shed.
Okay.
And
So the point is, any jaundice that is lasting more
persisting
than
more than
14
2
days warrants evaluation. So that is the point. So you have narrated, you have very beautifully shown the timeline of event. So
From the
this is
history, everything
happening.
gets like that. If they have done if they have done
No.
investigation 30th day from outside, we can.
Okay. Okay, please proceed.
On day 93, in view of conjugated hyperbilirubinemia, baby referred to MCH. Before that, baby had visit in outside hospital. No history of bleeding manifestation, no history of irritability, poor activity or seizures, no history of persistent vomiting, no history of fever, no history of abnormal body odor, no history of loose stools, no history of umbilical discharge. Child was on exclusive breastfeeding.
Is Dr.
Can
Litya
I go
around?
next?
Litya?
Yes, sir.
Litya, please try to answer these questions. She has shown in the slide like no history of bleeding manifestations, no irritability, so many things. Can you please tell why she is mentioning all this negative history?
Sir, features of liver failure,
You have to be very, very specific. Specific.
coagulopathy,
Okay.
seizures. It can be part of bilirubin encephalopathy, unlikely.
Bilirubin
But still,
encephalopathy. No, bilirubin encephalopathy here.
in this case, it is.
No, what sort of jaundice we are dealing with?
Sir, it's unlikely in this case. Seizures could be due to hypoglycemic seizures due to in liver failure also hypoglycemic seizures can occur.
Totals can cause seizure in the setting of conjugated hyperbilirubinemia. Leave alone the metabolism, leave alone the metabolic part, leave alone encephalopathy, all those parts. What alone? Totals can cause seizure in a cholestatic baby.
Sir, it can be due to coagulopathy itself can cause intracranial bleed.
Yes. Okay. So what about persistent vomiting? No history of persistent vomiting. What is she trying to rule out?
Sir, baby, it can be part of metabolic acidosis. That can be part of this a metabolic disorders. It can be part of metabolic acidosis due to a liver failure.
Okay. So what about the next statement? No history of abnormal body odor.
Trying to tell about phenylketonuria.
Phenylketonuria, how commonly does it cause conjugated hyperbilirubinemia? What is the metabolic disorder that can present with abnormal body odor in the setting of conjugated hyperbilirubinemia?
Tyrosine.
Tyrosinemia. Okay.
Tyrosine, we can get boiled cabbage odor.
Okay.
Irritability can be due to pruritus,
Yes,
or sepsis.
irritability can be due to pruritus
Can be due
also.
to
Very good
pruritus.
point. Very good point. Because in a 3-month-old baby, 2-month-old or 4-month-old baby, it will be very difficult to elicit that history. Simple irritability may be due to pruritus per se. Then, what is the relevance of no history of loose stools and all? Is Dr. Lita
UTI.
around?
Yes, sir.
Please answer. What are the conditions that she is trying to rule out by the statement no history of loose stool?
For
Vismaya itself, Vismaya, you can answer.
Loose stools can occur cystic fibrosis, and in umbilical discharge, umbilical sepsis can cause jaundice. And child was an exclusive breastfeeding.
We'll confine to loose stool add-on. UTI. Then, what are the metabolic disorders that can present with the conjugated hyperbilirubinemia and loose stools?
Cystic fibrosis.
So that you have mentioned. Then, how does hereditary fructose intolerance present? Can they develop diarrhea? So, E. coli sepsis. Okay. Okay, proceed.
A child was on exclusive breastfeeding, no intake of any.
One more point we should have added is whether the baby was gaining weight as expected. Okay, that's very important.
That was mentioned.
We didn't include that in the report.
Sir, that was included in that table. Initially,
Okay, also we should specifically mention with the breastfeeding baby was thriving normally. There are so situations, metabolic problems and sepsis situations, the baby may not be gaining weight. The gaining weight part is important. Okay. Then there are two very, very important situation which is relevant in this case. Child had 2 vaccinations, okay. Most likely. 90th day now. 42nd day and another one 10th week is over. Okay. Whether she took the vaccines and tolerated those IM injections at that time. Okay, many 2 IM injections most likely. Any 6 weeks baby had 10 weeks. Okay. A baby who has started a cholestatic disorder, early significant one, if she is not put on vitamin K, there will be hematoma formation. The cholestatic disorder, whatever, starting from the 2nd or 3rd week, if it will be significant enough, without vitamin K, IM injection and a girl child, whether there was ear prick or and a boy child, another shaving of this thing, all the cultural things where injury is possible, whether they tolerated that. The falling of umbilicus, IM injections, and the cultural things, whether there was any extra bleeding noticed during those periods, that is important in this case. Okay, proceed.
Development, gross motor partial head control, fine motor hand regard present, vision, eye fixing and following the object, social smile at 2 months, recognizes mother, respond to sound by startles, development appropriate for age, direct breastfeeding started half an hour after delivery, was on exclusive breastfeeding, immunization up to age, last vaccination taken on 17.
Miss Maya, go to the previous page. Developmental history, what is the relevance of development history going in depth is important in this case. Why?
Development in intrauterine infection like CMV, toxoplasmosis, brain will affected, can cause developmental
There
delay
are
and
underlying conditions, many of them
syndromes.
cholestatic situations. It may affect the
Yeah.
development in various ways, various manner in various disorders. Developmental can be affected. Okay, so we need to go in depth about the development of 93 days. What all things are affected in the all the 4 domains, and all those are important. All the normal, including the visual thing. Okay, is it important? Because there are metabolic disorders affecting the problems. Okay, then the other things like syndromic situations, Watson-Alagilla syndrome, trisomy situations, and all. So development analysis definitely important. According to you, all the 4 domains are normal.
Normal, sir.
And a child's vision, social smile, other things also perfectly normal. Vision, hearing.
Is normal, sir.
കേൾക്കുന്നില്ലേ എന്താ വിസ്മയക്ക് എന്താ ലേറ്റ് റെസ്പോൺസ് കേൾക്കുന്നില്ലേ കുഴപ്പമില്ല പറ
Vision and hearing normal, sir. And in galactose, cataract can be there.
Suppose you have some sort of a visual problem and you are having conjugated hyperbilirubinemia. Will that offer some clue to the etiology?
So in intrauterine infection,
how can the visual findings, how can the abnormalities in the sense of vision give you a clue regarding etiology? Can you mention 1 or 2 examples?
Chorioretinitis.
No. I'm not going to the interior part of the eye. You are observing from outside and you are observing some subtle findings. Cataract? No, not cataract, not structural. This is something functional.
Yeah, oil drop cataract can be seen.
Suppose you are having some abnormal ocular movements. I'm giving a clue. Abnormal ocular movement, and you find that the baby is having conjugated hyperbilirubinemia. That may be a very powerful clue to some storage disorder that can also present with the cholestasis. Or let me put it another way. What is the storage disorder that can present with the neonatal cholestasis? No. Storage disorder. The word is very, very clear. Is Dr. Lita around?
Glycogen storage disorder.
No. How does Niemann-Pick disease type C present? What is the eye finding? What is the eye finding?
Nystagmus can be.
Since sir was referring to the development part, so development is also very, very important in such a child. So it has to be given emphasis, especially vision, hearing. If you are considering the possibility of intrauterine infection, also vision and hearing becomes very, very important. So the cataract, etc., that will come to the examination part. This we are just observing. Just on casual observation, we are finding. Okay, please proceed.
Vismaya, it's not nystagmus.
Yes.
It's not nystagmus. What is it? നിഷ എന്താണ് തൃശ്ശൂരിലെ PGs എല്ലാവരും ഇങ്ങനെ ബോറന്മാരായി പോയത്? ഒരൊറ്റ ഒരാൾ പോലും ഇതിൻ്റെ അകത്ത് പാർട്ടിസിപ്പേറ്റ് ചെയ്യുകയോ ആ കുട്ടീനെ ഒറ്റക്കാക്കിയത് എന്താ? തൃശ്ശൂരിലെ
അറിഞ്ഞൂടാ സാറേ, ഇവിടെ ഇങ്ങനെ ആയിപ്പോയി. ഇപ്പോ പരീക്ഷ ആയതുകൊണ്ടായിരിക്കും.
ഒരു മയന്തന്മാരാണ് അവിടുത്തത്.
എല്ലാരും ഉണ്ട്, പക്ഷെ ആരും ഒന്നും അൺമ്യൂട്ട് ചെയ്തിട്ട് പറയുന്നില്ല.
അല്ല ഇറങ്ങി പൊക്കോളാൻ പറ. അതെന്താ അങ്ങനെ ആയിപ്പോയത്? It is a gaze. Okay.
No, sir, I was giving maximum clue so that she comes out with that gaze palsy.
Okay. Upward vertical
Okay.
gaze and lateral gaze are important. Okay. It is easy to
Supranuclear gaze palsy.
sideways gaze. Okay. That is important. Niemann-Pick disease gaze affect ചെയ്യുന്നു. Gaucher's വേറൊരു gaze affect ചെയ്യുന്നു അല്ലേ? അതെങ്ങനെയാന്ന് പറഞ്ഞു നോക്കണം കേട്ടോ. ഓക്കെ, ഗെയ്സ് ഇസ് ഇമ്പോർട്ടൻറ്റ്. തൃശ്ശൂരിലത്തെ എല്ലാ ബീച്ചസിന്റെ അടുത്തും എന്റെ പ്രൊട്ടസ്റ്റും എന്റെ എന്താ വിമർശനവും ഉണ്ടെന്ന് പറയും. ഇങ്ങനെയൊന്നും അല്ല അവിടുത്തെ കുട്ടികൾ ഉണ്ടായിരുന്നത്. എന്തൊരു പൊട്ടന്മാരാണ് ഒരു കാര്യത്തിന്റെ അടുത്ത് പറയാത്തത്. Vismaya, continue.
Vismaya, please continue.
Family history, no history of jaundice or liver disease in the family, no history of unexplained neonatal death or abortion in the family. He's the only child born out of non-consanguineous marriage. Socioeconomic history, five-membered family. Five-membered family, father studied up.
Please show the previous slide once more. Okay. Proceed.
Five-membered family, father studied up to +2 auto driver and mother studied up to +2 homemaker, belong to BPL family. According to modified Purushothaman scale, belong to lower middle class family. Summary: 93-day-old boy, term AGA, birthday 2.9.
Just the previous slide once more. Has this socioeconomic history got any relevance to cholestasis?
Sepsis can occur in
No, not sepsis. It is almost a what is an extinct entity. Some of the cooking practices and cholestasis. Is Dr. Harikrishnan around?
Yes, sir.
So what is
the socioeconomic status and cholestasis? In case of surgical cases, we may need.
No. Nothing of that sort. I was asking. Yes, Kirtana has answered. Who is Dr. Kirtana?
Sir, I am a resident in KIMS Health Trivandrum.
Okay. So it is what I was asking is some of the feeding practices, some of the cooking practices can result in cholestasis. It is an extinct entity now, but still, if somebody asks me, you should be able to tell. Indian childhood cirrhosis. Okay, please move on.
Summary: 93 days old male presented with he's a term baby, 2.99 kg, born to non-consanguineous marriage. Mother had history of fever in first trimester and gestational diabetes was there. No history of itching or jaundice in the antenatal period. Antenatal USG showing forward plexus cyst. NAPT workup for aneuploidy was normal. No family history of liver disease. And postnatal and natal and postnatal period uneventful, except jaundice. Presented with clay-colored stool for 3 days and high-colored urine for 1 month. Impression: neonatal cholestasis. Probable etiologies are biliary atresia and intrauterine infection. Because first in this biliary atresia to be ruled out because the baby is a well-thriving baby. There were no danger signs like failure to thrive, or child didn't have any other symptoms like vomiting, seizures, and all. My first biliary atresia from the history, and second, fever in first trimester. Can I go to next slide?
Yes.
ഒരു മിനിറ്റ് കുട്ടിയെ, how common is a biliary atresia manifesting without problems in the first month?
Common
What is the
total
problem? What is the problem in
34.
Yeah. If you consider biliary as the first possibility,
it's around 34% cause of total neonatal cholestasis.
the majority of the case of biliary atresia presents in a progressive manner. It won't be that late, I think. So you are considering biliary atresia first possibility. In this case, the early period, almost 60 days was totally not much of biliary. So usually progressively worsening jaundice will be there in many of the cases of biliary atresia. That's my understanding. So I don't know. Anyway, the other possibilities definitely is. Okay.
Examination child alert active. Examination child alert active playful. Vitals pulse rate 118 beats per minute. Respiratory rate 46 per minute. Temperature 36.7. Capillary refilling time less than 3 seconds. And pallor was present. Icterus
Yeah, video and there is not much of a jaundice.
eyes. Other part of the body not icteric. No cyanosis, clubbing, lymphadenopathy or edema. Urine examination done, which is not that much high color, but stool color is clay color and icterus present over eyes. Anthropometry weight 4.86 minus 2.23 standard deviation. Length 62 centimeter plus 0.2 standard deviation. And head circumference 39 centimeter minus 1.3 standard deviation. Head to foot examination, head size and shape normal, no facial dysmorphism. Anterior frontal neck normal, size 2/2. Eyes icteric, no cataract, no features of vitamin A deficiency, no microcornea, no cleft lip or cleft palate, nose normal, ear normally set, neck chest normal, skin and hair normal, abdomen distended. No rashes over the body, no bleeding manifestations. Limbs are normal. Pale extremities. External genitalia, no micropenis. Stretched penile length 2.5 centimeter. Systemic examination. Gastrointestinal tract. Upper gastrointestinal tract.
General examination in this case. Okay. What all things should be included in the general examination? Main category.
Eyes cataract should.
So rather than put and all, whether the child is the growth and development is up to the mark for a 3-month-old baby. What's your comment? Development in all the fields are normal?
Normal, sir.
Okay, all the fields are normal. Growth part?
Growth part, initially baby had some feeding issues, so that weight gain was not adequate. But last 2 weeks, baby had around 30 grams per day weight was there. Height and head circumference were normal.
What is the growth parameter suggests? Is it normal or deviant for a 3-month-old baby? What is the head circumference? What is the weight? What is the height? What is your proportions? All those things are important. That's what I'm asking you. What about the growth?
Head circumference is normal, sir. In the first 3 months, 6 centimeters should be.
You just tell the measurement.
Normal, sir. Normal.
That's all. What is the growth? You answer. Growth
normal.
Are normal. Weight is normal.
Weight minus 2.6 is low, sir.
Weight actual weight minus 3 4.86,
sir.
4.86. But it was 2.8.
2.9.
4.5 fairly well for the personal gaining weight. Minus 3 standard deviation of head circumference, is that important? Head circumference, each of the parameters are important. Head circumference important or
yes, sir. In congenital toxoplasmosis, hydrocephalus can be there.
That is important in many situations. Intrauterine infections, that's
metabolic disorders.
Which one will be important? Is it macrocephaly or microcephaly in the setting of cholestasis?
Both is important, sir. Toxoplasmosis, hydrocephalus, and microcephaly. Microcephaly, where CMV infection expression, Down syndrome, and rubella, congenital rubella syndrome, microcephaly can be there.
Macrocephaly?
Microcephaly and toxoplasmosis, hydrocephalus.
Oh.
Cytomegalovirus, according to you, it will not produce it will not microcephaly.
Microcephaly, cytomegalovirus, and
Will it be microcephaly always in cytomegalovirus?
always no, sir. Sometimes no. Normal head circumference.
Can be normal also. Head circumference can be normal. In this case, head circumference is important. Fondness you mentioned. Okay, after this comment about the development, after about this the growth part, then whether the child is sick or not. Is the child sick?
Child is a well baby, well thriving baby.
Well thriving, happy, happily playing. All those things are important. All the
well baby, sir.
There are few situations of cholestatic disorders. By the time of 3 months, the baby will be progressively very sick. That is one of the most important metabolic disorders, galactosemia and all. By 93 days, they'll be very sick. Okay. Abdominal distension, burst, all the situations will be. So it is not looking that sick. That is important. Okay. In the head-to-foot examination, many of the things are mentioned. You didn't specifically mention any bleeding manifestations obvious here. Any sandilasma palpebrum, any lipid deposits, and micronutrients which are dependent on the cholestatic disorders. A, D, E, K, all those things. Any skeletal changes of rickets. About the tone you need to mention. The extraocular movements are many ways relevant. Okay. Because there are a lot of eye findings in different ways. You said about the cornea, you said about the eye size, you said about the cataract, and a neurological point of view, a few of the metabolic disorders you said. Another one is extraocular movement and the floppiness, vitamin E situations. So ADEK deficiency, all those things are in the head to foot and general examination. Okay.
Ismaya, what is the importance of examining the tone in a baby with cholestatic jaundice?
Hypotonia in Down syndrome and hypothyroidism. Hypotonia can be there.
Yes.
And
what are the conditions where you can get hypotonia apart from Down syndrome? And,
Zellweger syndrome.
yes, Zellweger. Okay.
Systemic examination, yes, sir.
Developmental child appearance, non-dysmorphism is there in this case. Okay. Okay. Dysmorphic child and abnormally looking child are important because few of the syndromic situations will come in the India when you are discussing about the case. So dysmorphic facies is not there in this case. Zellweger is one, Watson-Allardyce syndrome is there, trisomies are there. So in this case, none of the stigmata of the genetic disorder is there in the general examination. So a lot of things are to be there in the general examination, in the head to put. Many ways they are important. Okay. Etiological.
Kismaya, suppose the tone is involved, tone is also affected, and you see that cholestasis is also there. Will there be a certain clue to another group of disorders?
Metabolic disorders.
No, not metabolic. Will that tone involvement, with that abnormal tone, may give you a suggestion regarding some other group of conditions, which can involve not only the liver, not only the brain. How does this mitochondrial disorders present? Can they also present with hypotonia?
Multi-system will be affected. Yes. Cardiac involvement, CNS involvement.
Okay.
Gastrointestinal tract, upper gastrointestinal tract, oral cavity normal, lower gastrointestinal tract, abdomen distended, shape and symmetry of the abdomen normal, all areas moving equally with respiration, umbilical central, inverted, no dilated veins or scars. Palpation, no local rise of temperature, liver palpable, 6 centimeters from right posterior margin, left.
No, just please.
Left lobe of.
Go very slowly.
Left lobe of. Left lobe of liver palpable, 3 centimeters from CT sternum. consistency, borders regular and rounded, liver span 9 centimeter, spleen palpable 2 centimeter from left costal margin, firm in consistency, hepatosplenomegaly present, no ascites.
Can you go to the previous
Auscultation.
slide? Can you go to the previous slide once more? No, the previous one, inspection slide. Okay. Please show the next slide. Is Dr. Harikrishnan around? Is Dr. Harikrishnan around?
Yes, sir.
Previous slide. Palpation slide. Please try to interpret the findings.
According to this, there is hepatosplenomegaly for the age, sir.
Why do you say there is hepatosplenomegaly?
There is enlargement of the spleen when compared with the age limit, sir. Usually, we expect only at birth 5.5 centimeters of liver span is normal, and around 3 months we can expect only 6 or 7 months, sir. So 6 or 7 centimeters, sir. Here it is around 9 centimeters, and spleen is also palpable 2 centimeters under the left costal margin, sir. So we can tell there is hepatosplenomegaly in this case.
Any suggestion of the process that is causing hepatosplenomegaly from the physical examination finding? Do you feel that this is a static problem or a progressive problem? Based on the palpatory findings, do you feel that we are dealing with a progressive pathology or with an innocuous pathology?
Yes, sir. It could be a progressive pathology, sir.
Why do you say so?
Because it is present since birth.
No. Just take lead only from the palpation finding.
Yes, sir. There is firm consistency is firm here.
Firm liver. Okay. Anything else?
And left lobe of liver is also palpable, which is usually not palpable in other in regularly.
Can you make a conclusion that the baby is already has? Can you make a conclusion that the baby has already gone in for some pathological complication?
Yes, sir. Yes, sir. We can expect a child to be chronic liver disease or cirrhosis.
Okay. Ismail, please continue.
Auscultation of normal bowel sound present, no bruising. Ophthalmological examination normal, fundus normal.
Auscultation. Okay.
Normal bounce. Fundus examination done, no.
Pre-fluid and pre-fluid.
Echo was taken later, which were normal. And other system examination, severe response is present, no.
Please go back to the previous slide. Is Dr. Litta around?
Yes, sir.
So what are the ophthalmological findings you will be interested in this setting? Starting from external to internal.
Sir, external epicanthal fold Down syndrome, abnormal eye movements, cataract in galactosemia, then brushfield sports iris in Down syndrome, chorioretinitis in the CMV infection, then Alagale posterior embryotoxon in Alagale syndrome, then
inside the retina, if you look for some stigmata of storage disorders.
cherry red spot.
Where? What is the condition that you are trying to rule out?
It could be Niemann-Pick disease.
So in the external examination, I think you should look for the complications of fat-soluble vitamin deficiency also, especially vitamin A. So that should also come in the important findings that you should look in the eye. Okay.
Cardiovascular system examination, S1, S2 present, no murmur. Respiratory system, normal vesicular blood sound here, no added sound. CNS, anterior normal, sensory normal, moving all limbs, tone normal.
Yes, just go back to the previous slide. How does cardiovascular system examination guide you in the etiology as well as complications?
In Alagille syndrome, we can peripheral pulmonary stenosis and TOE can be there. In Down syndrome, endocardial cushion defect can be there. In mitochondrial disease, cardiomyopathy can be there. And biliary atresia can again can be present along with cardiac anomaly like dextrocardia.
Yes, good.
Vismaya.
Heart disease.
Vismaya.
Biliary.
Hello.
Welcome, sir.
When you are thinking about the association of a system with another system, now we are talking about a liver disorder, cholestatic, different possibilities you are considering, and they are examining different systems for the reason whether this will contribute for your diagnosis or the result of this problem. That is why you are examining the cardiovascular system. Okay. So there are many ways this can be affected and many clinical points you should be looking into. Okay. When you are thinking about a chromosomal or a genetic or a syndromic situation, you are looking for the structural malformation of the heart. Example, Watson-Alagille, trisomies situations where we say the endocardial cushion defect, intrauterine infections, you are looking for a PDA, like that. So in the cardiovascular system, any structural problems of the heart. Okay. When the cholestatic disorder, you are considering the mitochondrial disorder, you are looking for a myocardial or a conduction system problem. So in each of the situations, what you look for are different. In a myocardial situation, you are looking for the LV cardiomegaly situation and a silent heart with a third heart sound. Okay. Muffling of the heart sound and a third heart sound and a cardiomegaly and a regular rhythm are what you expect in a case of mitochondrial disorder. Okay. In a structural disorder, different ways of the chamber enlargement and the sound and the murmurs. Okay. When you are looking for bile salt accumulation, it is for the rate. When you are suspecting a rhythm abnormality in a mitochondrial disorder. So when you are examining, different points are helpful in different ways. Pulse rate is important, pulse rhythm is important, JVP is important, cardiomegaly is important, murmur is important. They're all different ways. Okay, it's not merely enough to say that S1, S2 is normal, so move forward. So think about the relation and look for it. That is how you assess a system when you are examining another system. Okay, in the nervous system, what all ways this can be affected? We discussed. Okay, there can be storage disorder presenting with ocular involvement. There can be developmental delay. There can be tone abnormalities. Thyroid, there can be hypotonia and there are reflux changes. So like that, rather than just moving on, CNS is normal. So what all things I considered and what all things I look for. So that should be the way in which you see the other systems. When you move forward to another system, it is not enough to say that other systems are normal. So what all things I considered during the evaluation. What all things I looked for? അങ്ങനെ വേണം പറയാൻ. CNS-ന്റെ അകത്ത് more important is the tone and the reflexism. And symmetry and asymmetry. There can be an IC bleed leading on to features of the sick child fontanelles, this thing, altered sensorium and focal neurological deficit. And recovered from that case, again, asymmetrical child, asymmetrical neurological deficit. In a case of storage disorder, bilateral symmetrical tone and reflex changes and ocular crane nerve changes. In a vitamin E deficiency, hypotonia and external ocular. So, in short, you should be considering what way the another system is affected and what to look for. അങ്ങനെയാണ് other systemത്തിന്റെ കാര്യങ്ങൾ പറയേണ്ടത്. Okay, move on.
Very good point, sir. So, Vismaya, just hold on. Suppose you are permitted to check the pulse oximetry. Can it help you in assessment of the child regarding a particular complication which these babies are prone to develop? Vismaya, are you here?
I don't know, sir.
Have you heard about hepatopulmonary syndrome?
Yes, sir.
So some of the cholestatic disorders are known to develop it quite fast. So it is having some diagnostic significance also. Suppose they have clubbing and you see that the baby is having orthodeoxia, may not be elicitable in a small child, but if suppose you find the saturation is coming down, apart from the structural defects which sir was alluding to, development of hepatopulmonary syndrome, that has got a very important prognostic role in planning the management also. So even if you get a case of cholestatic disorder, don't feel that the other systems can be very lightly mentioned. There are a lot of association as sir mentioned. So you should have a very good checklist regarding association as well as complication. Similarly, respiratory system also has got similar implications. Because of lack of time, I'm not going into those details. Read those associations also.
Okay. Just Prasanth sir was talking about pulse oximetry. Okay, so what is the specific pulse oximetry finding which you will be looking for in this case? ഇപ്പൊ സാറ് പറഞ്ഞത് ശ്രദ്ധിച്ചോ? ലിറ്റ ഹരികൃഷ്ണൻ രണ്ടാളും ഉണ്ടോ?
Hypoxia, sir.
എന്താ?
Sir, in pulse oximetry, we can expect hypoxia in case of hepatopulmonary syndrome.
No, that's not enough.
Platypnea.
Not enough.
Platypnea.
word പറഞ്ഞിരുന്നു, എന്തായിരുന്നു അത്?
No, I had mentioned what is orthodeoxia.
Orthodeoxia.
ശ്രദ്ധിച്ചിട്ടില്ല ആരും അല്ലേ?
When standing position, saturation with called orthodeoxia.
The problem is you should not be myopic when you examine a child. Your horizon should be wide. If you are myopic, no, you will just concentrate on the liver part alone. Sir was very beautiful in narrating the association. So it will be very strong in the interfaces also. Okay, please proceed.
Summary. The baby boy, term AGA, birth weight 2.99 kg, wanted non-consanguineous marriage. Mother had history of fever in first trimester, gestational diabetes on diet control, no history of itching or jaundice in antenatal period, and antenatal UST showing forward plexus, and NIPT workup done was normal. No family history of liver disease, uneventful natal or postnatal history with complaints of clay-colored stool for 3 days and high-colored urine for past 1 month. Examination, well baby, icterus present, pallor present, firm hepatosplenomegaly, impression, neonatal cholestasis, etiologies, biliary atresia, and intrauterine infection.
Even after examination, you are not expanding your etiologies. You are still comfortable with the biliary atresia and IU infection alone. Even after so many examination findings, you are sticking to the, you would like to, you don't want to modify the etiologies.
Baby, well-thriving baby, etiology is more likely biliary atresia.
Only biliary atresia you would like to consider.
And also hepatosplenomegaly is there. Storage disorder should be ruled out, but no other symptoms of storage disorder. Symptom-wise, no other symptoms of storage disorder is there. So
Need not be there. Could be in the evolving phase. Some of the other metabolic disorders, they are not in the strict sense metabolic. That can present just like biliary atresia. You have basically neonatal cholestasis with ecolic stools. You know what is ecolic stools? Pale stools. So the DD has to be very broad. Not only biliary atresia alone. It can be structural problems like allergy also, because the facies may not be explicit at 3 months, 4 months, etc. Those typical facial profile will evolve later. So you cannot discount on all those possibilities. So just restricting the etiology to biliary atresia and IU infection may not be a good proposition. Sir,
all other extra causes.
Purushothaman sir, she is sticking to only these two etiologies.
Examination ശേഷം കുറച്ചുകൂടി ഡിഫറെന്റ് ആയിട്ട് നിങ്ങൾ ആലോചിക്കാമായിരുന്നു.
Yes, Vismaya, please proceed.
Investigation
Other system.
കഴിഞ്ഞോ?
Investigation complete blood count HB 10.3, total count 8,000.
No,
8,700.
No, please hold. Please do not show the investigations. You just tell what all things you will do in a very systematic manner. Then we will verify what you have done. You have been given the child. You are permitted to do. What is the purpose of your investigation? One is to confirm.
Sir, neonatal cholestasis have multiple etiology. So when take like that, first we have to think.
No, Vismaya, please listen. The purpose of investigation has several levels. One is to confirm your suspicion. That is, you have to prove that it is neonatal cholestasis unequivocally. So there are some investigations that you will do on that count. Then only the etiology workup, complications, everything will come into the picture. What you are trying to narrate was a textbook pattern of telling hemogram, those things. Those we are not interested. What you will do alone, that alone you tell.
First, we have to confirm whether it is direct hyperbilirubinemia. So we will do liver function test. If direct bilirubin is more than 20% of the total bilirubin, we can confirm it as direct hyperbilirubinemia. And we will do along with that, if SGOT, SGPT elevation is there, there is hepatocellular that indicate hepatocellular injury. And we also to do INR to look for coagulopathy, and we will give vitamin K. If it is corrected with vitamin K, only it is due to cholestasis and vitamin K deficiency. And also along with we will do GGT to look for biliary injury. And also along with that we will do complete blood count. And if it is a well baby, we will think sick baby, and we should look for whether the baby is well baby or sick baby. This child is a well baby and well thriving baby. We will do USG abdomen along with that.
Just Vismaya, hold on. Is Dr. Harikrishnan around? Is Dr. Harikrishnan around?
Yes,
Harikrishnan?
Yes, sir.
What is the do you agree to her definition of conjugate hyperbilirubinemia, or do we have a better definitions right now?
Yes, sir. If total bilirubin is around 5, then we expect at least direct fraction to be more than 1. Sir.
No. Is Dr. Litta around?
Yes, sir.
So what is the new definition for cholestasis? So if you happen to find a direct bilirubin more than 1 milligram per deciliter, that is conjugate hyperbilirubinemia. Whatever you are mentioning these are all old definitions. So many of the recent guidelines say that if the conjugate hyperbilirubinemia, the conjugate bilirubin is more than 1 milligram per deciliter, that you have to take it as cholestasis if that is persisting beyond 14 days of life. Okay, Vismaya, come back. Come back to your discussion.
Vismaya, one more point. All teachers will not like going directly to the blood investigations. Make use of the bedside and a simple urine investigation always. In this case, it may be very clear. Still, you need to tell about the urine, bile salt, bile pigment always, and maybe microscopy also before you go to the blood examination. Okay, and see the macroscopic appearance of the stools. These are very, very important. See the urine, see the stool, and do the bile salt, bile pigment. Okay. Then,
What is the biochemical test that you do for estimating bilirubin? What is the name of that reagent?
THRISSUR reagent, Vandenberg test.
Yes. Okay. Yes, please proceed further.
Can I continue, sir?
Yes, please.
Here we have done total bilirubin and direct bilirubin, and all values we can see that it is more than direct bilirubin more than 1, and it is more than 20% of the total bilirubin. And SDOT and SGPT initially 184 and 124, and it is increased further investigation. And INR 1.76 is corrected with vitamin K.
So
And
what
total,
does that convey? Vismaya, what does that convey? You are telling, you are making a statement that INR got corrected with vitamin K. So what are you trying to convey?
Sir, INR is deranged means this can be to cause vitamin K deficiency or a liver synthetic function, because liver is synthetic all clotting factors. And 2, 7, 9, 10 clotting factor need activation with cofactor vitamin K. If vitamin K is deficient,
is it vitamin K deficiency or something else?
There is INR can be increased. If we given vitamin K, INR
is it vitamin K deficiency or some other thing? You have cholestasis and your fat soluble vitamins are not getting absorbed. It is malabsorption.
Malabsorption. Malabsorption in cholestasis. A, D, K vitamin cannot be absorbed properly, so that INR deranged is corrected with vitamin K. So that production of clotting factor is not affected. Liver synthetic function is not affected. And also total protein and albumin.
Okay.
And GGT, which is 799, which is increased, which indicates biliary injury. In biliary injury, GGT is increased. And urine examination, bile pigment present. Only conjugated bilirubin will dilute in water, so that bile pigment present in urine indicates that conjugated hyperbilirubin. And there is no UTA, urine pulse sensitivity was sterile. To rule out other investigations, we have done.
You go back to the previous slide. Previous one. Again, go back to the previous one. Anything very, very important, reading between the lines. Everything is obvious, but there are certain things hiding here. What are the things which we need to look for? Reading between the lines, which may be giving the clue for the diagnosis. You didn't make use of these investigations properly. What are the things which are important here?
Direct hyperbilirubinemia and GGT elevated.
That is obvious. Direct hyperbilirubinemia. What are the things which you need to look for? What about the transaminase? Is there anything?
Increase. That is biliary hepatocellular.
Hari Krishna, is that enough? Is that comment enough?
In hepatocellular injury, transaminase will increase.
I'm not happy with that statement. Hari Krishna, Licha, Arulli. Which enzyme is increased here? In a liver injury, which enzyme will be increased?
Who is Dr. Ashida Chakradharan? Is she a resident?
Sir, IMCH, from IMCH.
So please tell that.
Parnolo.
Sir, OT is more elevated than PT in this case.
Unusual. Okay. When you get a PT less than OT in any liver disorder, you make use of all these things. It's not merely enough to say that transaminase is elevated. You make use of this thing, how many times it is elevated. It is 3 times, 10 times, in hundreds or in thousands. That is one way of analysis. The second one is the ratio, which is predominantly elevated. OTPT, and you need to calculate the ratio of OTPT. All these are important for diagnosis. Okay. Then something which you didn't make use of is the GGT and alkaline phosphatase. And those things also need evaluation. How that is helpful? The GGT analysis is helpful here. What way?
Ismaya, please answer to sir.
Sir, GGT elevated means biliary injury is there, and it can be used to distinguish between PFIC types.
PFIC and one more thing. PFIC, right? PFIC, the various types of PFIC is there. Anything else? Biliary atresia also. What way GGT investigation and compared to the alkaline phosphatase is helpful in PFIC and biliary atresia? What way?
Biliary atresia.
What way?
And PFIC 3 GGT is elevated because in that case, phosphatidylcholine excretion is affected. Phosphatidylcholine actually bile acid causing biliary injury. Phosphatidylcholine neutralizes the bile acid.
My question is, how the interpretation of GGT alkaline phosphatase ratio or the relation is useful to diagnose PFIC on one side and biliary atresia on the other side? Is useful ആണോ അല്ലയോ? നേരത്തെ ആരാ ആൻസർ പറഞ്ഞത്?
Ratio will be low in PFIC type 2.
Okay.
Basically, if you have a low GGT, probably that may be a clue to conditions like PFIC other than type 3. Because we have the list of PFIs is expanding day by day. Other than type 3, almost all will have low or normal GGT. Then you can have low GGT in another group of conditions called the bile acid synthetic defect. There also you can have low GGT. Sometimes you can get a panhypopituitarism as a cause for cholestasis. There also you will get low GGT. So these are some of the settings where you get low GGT. And as Sir said, in biliary atresia, we usually expect the GGT to be high, on the higher side. But exceptionally, it can be low in biliary atresia also, very rarely. But the conventional teaching is like GGT will be invariably high.
The only point I want to highlight is, don't move on. You need to read in between the lines. There can be clues. There are certain clues hiding in the Wilson's disease analysis is classical one. Unless you analyze the result, you may miss the clue for the Wilson. Just like that here also. Okay, move on.
Okay, what is the next investigation you would like to do? Urine CMV. Please show the other slide. Next slide. Vismaya.
Next week.
You are considering a CMV infection for this case?
Sir, mother had history of fever in first trimester, so that we done this investigation.
Will the baby be well thriving and growing very well in the case of CMV infection? If it's an intrauterine infection, that will be the phenotype of neonatal hepatitis like. Is the baby will be well thriving or will the baby will be sick looking?
Baby is well thriving. Baby,
the case
sir,
of-
first week.
In the case of neonatal hepatitis, do you think that the baby will be well thriving or it will be sick?
Sir, extrahepatic biliary atresia cause can be due to some infections. CMV infection can cause
Now, those associations are not
extrahepatic biliary.
causally proven, but in some cases you can have. Test the urine
We have just
PCR. Will you take the urine CMV PCR positivity as a
no, sir. We will we send blood CMV PCR, quantitative PCR. Its result is
So how do you
awaited.
make a diagnosis of congenital CMV infection? There is a timeline for that. What is the timeline? Within how
It
many
should
days you
be
should make?
confirmed within 3 weeks. It should be
Yes, within
confirmed within
21
3
days
weeks.
you should do. What they are telling is like you can do even check for the viral load from the saliva as well. Is also equally good. But if you do want to make congenital CMV, you have to make within 21 days. Beyond that, if you happen to get CMV positivity, that alone cannot be attributed as a cause for genital cholestasis. You may be missing the target. It may be just a red herring alone. Okay, please proceed.
In between
Blood
child,
culture.
we had sir, in between child had fever, we have sent blood culture. 2 days of fever was there, so that we sent blood culture. It was positive, Klebsiella positive.
But
It was
your
positive, so that
description of a well-thriving baby and sepsis doesn't go together, Vismaya.
sepsis unlikely, sir. But we got this positive result, so that I showed it. Because of fever, we had sent blood culture, and fever subsided within 2 days, sir. After
When the
admission,
hospital acquired
only
something. Or even UTI was there? No, urine was sterile.
no.
Okay, what is the next investigation that you should have done without wasting time for urine PCR?
USG, sir.
No. Why are you
USG.
hesitant? Why are you hesitant to do ultrasound?
USG, sir. USG next is
No,
day
these are
2.
all you to tell what is done in practice, not all the theory stuff.
Okay, sir. We have done USG abdomen as the baby is a well thriving and pale color stool was there.
Okay.
So
before you do just Vismaya, before you do ultrasound, what all preparations you will do before subjecting the baby to ultrasound? I think is Dr. Harikrishnan, Litta, or Dr. Rosemary around? One of you can answer.
Sir,
At
2
least
times USG should be taken 4 hours of fasting and then immediately after breastfeeding.
Okay. What is the idea? What is the idea behind that? What is the idea? What is the whole idea behind that?
Sir, in a fasting state, gallbladder will be distended as it stores the bile.
Yes. How distended it should be? How much distended it should be? Minimum.
3 meters.
You are right. How
3
much distended it
centimeters.
should be? It should be distended not less than
3 centimeters.
Not less than 20 millimeter or 2 centimeters. Okay. Then what else will you look into the gallbladder? What other attributes will you look in the gallbladder apart from the length?
Any sludge, any stones?
Not sludge really. You have to look into the internal wall appearance, contour, etc. It has to be very regular. So all these things should be looked into the gallbladder. Apart from gallbladder, what all things will you pay attention in the ultrasound?
Any about the size, echo texture, intrahepatic biliary radical dilatation, about the visualization of the CBD, any in biliary atresia, triangular coat sign in biliary atresia.
Okay. Will you look for some of beyond liver? Anything else will you look in the ultrasound beyond liver and gallbladder?
Portal vein.
portal vein.
Then this
What about the spleen? Suppose you have a
sir, whether the spleen is enlarged or whether there is a asplenia or polysplenia.
yes.
By we have 271 for 2. So blazing away to 126. I'm doing it 100 as well. So very good looking partnership. As things stand here, 35 over, so 161 for 4.
Can you please mute Dr. Prasanth's audio is on.
Mute.
Yes, please continue, Vismaya.
Sir, USG abdomen of baby showing liver size enlarged 9.1 centimeter, echo texture normal, portal vein normal, spleen 7.5 centimeter, gallbladder before postprandial no changes, gallbladder contracted, and in second picture we can see above the portal vein there is a hypoechoic area, that is the bile duct. In the first picture above the portal vein, we cannot see that hypoechoic area. It is hyperechoic, which indicates biliary atresia.
Vismaya, we will not go into those finer details. Please carry on. So to conclude now.
So USG showing biliary atresia.
Why did you do HIDA scan for this case? What was the purpose?
Sir, already child presented in late case 93 days, so that we have to confirm.
What is the specific situation where you will order for HIDA scan? What was the compelling indication here?
Sir, we have to first rule out biliary atresia. Sir,
So
it's a late.
just by
It's
doing
already
HIDA
late.
scan, just by doing HIDA scan, will you be able to confirm biliary atresia?
No, sir. Intraoperatively, we can do cholangiogram. That is the gold standard method.
If you have a phase 2, there is no point in doing HIDA scan. You will be wasting additional 1 week just for priming. It may be helpful if you have an ambiguous 2. Okay.
After HIDA scan, the first picture showing normal HIDA scan, the dye reaching up to duodenum, and the second picture is baby's HIDA scan. Liver uptake is normal, and dye not reaching to the duodenum even after 24 hours. After HIDA scan, we have consulted pediatric surgery, and first thing we have to rule out was biliary atresia. So that surgery was planned in intraoperatively. They planned for intraoperative cholangiogram, and if biliary atresia diagnosed intraoperatively, they plan for Kasai procedure, and we have done Kasai procedures.
So what happened to the baby subsequently? What happened to the baby immediately after the HIDA scan?
HIDA scan, after HIDA scan, biliary atresia suspected, and we have consulted pediatric surgery, and baby shifted to the pediatric surgery for laparotomy and Kasai procedure.
The perioperative findings were consistent with that of biliary atresia.
Yes, sir. This is the perioperative finding. The liver is cirrhotic. You can see the first picture is the baby's liver. Liver is cirrhotic. Normal liver is the second picture. And in our pediatric surgery, we have done this procedure. And we can see that liver is cirrhotic and the gallbladder is contracted. They have injected saline into the gallbladder. After injection of saline, we can see that gallbladder enlarged, and after that they will reaspirate fluid from the gallbladder, sir. You can see that after injecting saline gallbladder enlarged, and they will re-aspirate from the gallbladder, and they didn't get bile.
Okay.
After re-aspirated, no bile. If bile is absent, biliary atresia type 2A, B, and 3 can be there. Bile is present, other distal obstruction or biliary atresia type 1 can be there.
So what was the
This,
case in this guy? Don't go into the theory part and all. Leave alone. Leave alone. So they did Kasai procedure.
Yes, sir. Yesterday surgery done.
Which day? 90th day or 95th day?
No, sir. In between, child had fever, so that anesthesia delayed the surgery. Yesterday only surgery done.
So it would have been over more than 100 days now. By now.
Yes, sir. Prognosis is bad. It should be done within 60 days.
60 days. So baby's date of birth was in October now. October 24. So it will be now more than 120 days right now.
Yes, sir.
So after surgery, will you be happy? Will you be happy to send the baby? What are the two things which you will be interested after the surgery?
After surgery, we should look for total bilirubin and direct bilirubin values. It should be normal. It should be decreased within 3 weeks, ideally. And if not, definitive procedure is liver transplantation. Maybe this child needs liver transplant already.
What was the timeline which you mentioned? Within how many days the bilirubin should come down?
3 weeks, sir.
No, it is 3 months actually. 2 to 3 months, there are variable definition. By 2 to 3 months, the bilirubin should come down to less than 2 milligram per deciliter and the stool color should change from pale to yellow. These are the two things that should happen to assess the success of Kasai procedure. So what is the complication subsequent to Kasai that these babies can have?
Cholangitis can be.
That is the actual procedure. That is the actual procedure in Kasai portoenterostomy. What is being done actually?
Portoenterostomy. We have remove extrahepatic tissue and
you are removing the atretic portion and you are making a row and Y and putting the loop into the portohepatis.
Yes, sir.
Okay.
Prasanth, what surgery about the liver transplantation? You need the bile duct system also intact. So auxiliary liver transplantation will not be helpful.
Auxiliary transplant will not be helpful, sir. Auxiliary transplant can be done only in a setting where spontaneous regeneration is possible at some point of time. Here it cannot be attempted. Here the child is already cirrhotic by the time it has. We'll have to go for orthotopic liver transplantation, not auxiliary. So what about the general management, the other management after Kasai procedure? What all things you will ensure? Do we have time, madam? It's already 1.5 hours.
Time already, and I think we'll
we can
get.
It's okay. It's okay. We can another. Sir, actually, we can take another 5 minutes to wind up.
5 minutes, and we'll get comment from Banu sir and Riya sir. Both of them are the doyens in the field. We'll get comments from them also. Prasanth?
Can I tell? Antibiotics should be given. Sir, antibiotics should be started.
Please tell me in brief about the prescription that is given to this baby.
Okay, sir. Antibiotic and vitamins.
First and foremost, the baby has to be fed now. Nutrition is the first thing. Then only the drugs come into the picture.
Vitamin, fat-soluble vitamin should be given, and vitamin A, D, E, K should be given, and water-soluble vitamin twice daily requirement, and other multivitamins should be given, and direct breastfeeding should be continued when baby is okay, and choleratic agents should be given, also deoxycholic acid.
So Vismaya, what is the practical problem of giving vitamin A like this? So what do we follow here practically is this: we give a checklist wherein we have a set of medicines which are given on a daily basis. Then there is a group of medications which are given on a bi-weekly basis. Then there are some medications which are given on a twice a week basis. Then there are a group of medications which are given on a monthly basis. Because practically it will be very difficult to give formulations like this. What is the strength of vitamin A preparation available? What is the strength of vitamin A preparation available commercially? So being residents, you should make it a point to know the strength of each and every medication that you are prescribing. It is very, very essential before you prescribe any drug. You should know the drug before you prescribe, and you should know the practicalities of prescribing all these things. So what we do practically is a checklist. Vitamin A, what I advocate is like you give on a 1 capsule every 2 weekly, 14 days. Vitamin E, vitamin D, and all those things you can give daily. UDCA also you can give on a daily basis. Vitamin K, I give on a bi-weekly basis. That is every Monday and Thursday, we'll be giving a quarter of 10 milligram tablet. So that is the way we will be giving. So the practical point should also be kept in mind when you prescribe, rather than theoretically mentioning. Hope you are getting what I am saying. Is it clear, Vismaya?
Yes, sir.
Okay. Sir, Purushothaman sir, anything further to be added?
Thank you. I will invite comment from Banu sir. I thought Ria sir was here. Actually, he's not there, I think. Banu sir, are you there? Banu sir, he has left.
Banu sir message അയച്ചിട്ടുണ്ട് ചാറ്റിൽ.
Banu sir ഉണ്ട്. Banu sir. Comment sir.
No, yeah, I was telling that I really enjoyed it, and Purushothaman sir and Prasanth did a wonderful job, and Vismaya did a very good job of presenting the case. Now, I usually tell the residents 2-3 things. One, the most common reason for neonatal cholestasis in a full-term baby is biliary atresia. Okay, so that is definitely to keep in mind. Next, when the baby is jaundiced more than 2 weeks of life, the most important thing is to make sure to find out is it direct hyperbilirubinemia or indirect hyperbilirubinemia, because the workup and the etiology are totally different. If it's direct hyperbilirubinemia, keep in mind 3 groups of conditions. One is you look for conditions which are life-threatening, and unless you intervene right away, you may lose the baby. That is gram-negative sepsis, E. coli UTI, galactosemia, things like that. So those things has to be looked in first. So taking appropriate cultures, if it is suspect, gram-negative sepsis, and start on appropriate antibiotics, all those things has to be done. If once that is done, the next is you look for conditions that are modifiable by your action. The most important condition being biliary atresia, because you can do something to change the outcome if you intervene on time. So you don't want to lose the time. So it's very important, look for conditions that you can modify. And that is, one is biliary atresia, then cold ductal cyst, which you can of course treat with a surgical intervention. So things like that has to be looked into. Once those things are ruled out, you look for other conditions, because in the textbook, if you look, you will find hundreds of causes of cholestasis. You cannot look for everything under the sun at one go. You look for conditions which has to be intervened right away, otherwise you may lose the baby. Then look for conditions which are modifiable with your action. Then look for conditions, rest of it. you go by in that order to intervene, because you cannot do everything under the investigation, all the investigation. You just cannot do it, and it's not impossible. It's not necessary also. So those are things that we have to make sure that is we have to keep in mind. And I'm very glad Prasanth clearly pointed out the importance of HIDA scan. Importance means, or lack of importance. If you really have a pale stools, you do not need HIDA scan. If the surgeons are willing, you can take the baby for an operative cholangiogram to confirm the biliary atresia, so you don't have to waste 1 more week or 5 or 6 days with a phenobarbital or a UDCA to prime the baby to get the HIDA scan done. So it's very, very important to avoid wasting the time, especially like this baby who present only on day 93 to you, so you already are wasted a lot of time before the baby came to you all. So it's very important to avoid wasting further time to get that. So those are important. Other things, Purushothaman and Prasanth, you did a wonderful job of explaining and analyze them in critical fashion, so that residents can learn from that. So that's very, very good. Thank you.
Thank you, sir.
Thank you, sir.
Prasanth, I think we can wind up. Latika, Riaz, anything more to tell? And Mohandas has joined later.
Mohandas sir was here.
Lengile, Dr. Riaz, can we wind up?
Ajit sir ഉണ്ട് സാറിന്റെ യൂണിറ്റിലേക്ക്
Ajit sir, please.
sir.
Yeah, excellent discussion, Dr. Prasanth, and Purushothaman sir added flavor to your discussion, and Vismay also you did well. I think what Prasanth said is that if it's a well baby, then you don't have to waste time in doing many other investigations. You can directly go for ultrasound and see whether the child is having biliary atresia, because we don't have to waste time. That is very important point. And this child, actually, we wanted to do this one, peroperative cholangiogram, but I think the surgeons, they wanted to have a HIDA scan before that. Anyway, they will be counseled regarding liver transplant, and that will be that way to go. And I think liver transplant might save this baby. I hope that goes well. And Prasanth, we might be referring this child to you for the transplant. Hello.
Sir, hope the residents are benefited by the discussion and the approach.
Definitely. Your discussion was really enjoyable. I enjoyed last 1 hour. It was really enjoyable, and I hope many of the PGs, even though many were, I think many people, they responded to your questions, and I liked the discussion very well. Thank you, Prasanth, and thank you, Purushothaman sir.
Thank you, sir. Thank you, sir.
താങ്ക് യു. അപ്പോൾ തൃശ്ശൂരിലെ PGസിന് ഞാൻ സ്പെസിഫിക് ആയിട്ട് എടുത്ത് ചീത്ത പറഞ്ഞു എന്നുള്ള കാര്യം, റെസ്പോൺസ് പോരായിരുന്നു ഇനിയത്തെ ഡിസ്കഷൻ്റെ അകത്തുള്ള റെസ്പോൺസ്.
സാറേ, അവരെല്ലാം ഓടി വന്നു, അവരുണ്ടായിരുന്നു, കുറച്ചുപേരൊക്കെ ആൻസർ പിന്നെ പറഞ്ഞു. ഹരികൃഷ്ണ ലിറ്റയൊക്കെ.
ഞാൻ അതിൻ്റെ അകത്ത് തന്നെ നിൽക്കുന്നു കേട്ടോ, അടുത്തതിന് നന്നായിട്ട് പറയുന്നു, തിരിച്ചെടുക്കാം. ഓക്കെ,
Thank you, Prasanth.
Okay, madam. Thank you for the opportunity.
Thank you so much. Good night.
Thank you. Good night.
Good night.
Bye.